Welcome to this brief talk on closing capacity. The syllabus says describe, meaning describe or detail, closing capacity and its relation to airway closure. So not just a summary or 2 points, but to be able to fully describe it. You also have to explain or make plain the clinical significance of closing capacity and how it is measured. The syllabus clearly states you should know this topic well. A definition, quite simply, a capacity is the sum of two or more volumes. Closing capacity is the sum of the residual volume and the closing volume. Closing volume is the volume above the residual volume where airway closure begins. Closing capacity is the total volume in the lung where airway closure begins. Closing volumes with age. Closing volume is 10% of your vital capacity in a young adult. It's 40% of vital capacity or equaling functional residual capacity at the age of 65 in a normal individual standing up, or at the age of 40 to 45 in the average individual lying supine. Closing capacity also equals functional residual capacity in the neonate. So therefore the elderly and the neonate have some similar characteristics when it comes to closing volume. Why is this important? If closing capacity is greater or equal to the functional residual capacity, then airway closure is occurring during normal breathing. This opening and closing of airways increases the work of breathing and decreases the efficiency. Similarly, if you consider that any factor that decreases functional residual capacity, such as obesity, will push the functional residual capacity down further away, or at least under the closing capacity. Therefore, as your functional residual capacity decreases with disease, your work of breathing increases. This is also important because once an airway has closed, there is no ventilation occurring to that airway, but some blood flow continues, even though it will be less than when the airway is ventilated. In practice, this equals a shunt. Remember that an increased shunt equals decreased oxygen delivery. It's crucial to understand that shunted blood will have a saturation of 75% or less, and this cannot be adequately compromised by equivalent rise in PaO2, as far less oxygen is dissolved in blood as is carried by hemoglobin. This means that unless you add a lot of oxygen to the rest of the blood, it won't fully accommodate for the desaturated blood. It's also to understand that an increase in closing capacity in the elderly and neonates means that they are more vulnerable to respiratory failure and that this will occur more rapidly. Consider as well that any disease that increases oxygen consumption, whether that be sepsis or a seizure or resting tremor, anything that increases the oxygen consumption will accentuate the oxygen desaturation, and a morbidly obese elderly patient breathing 100% oxygen who is in septic shock could very well desaturate in less than 30 seconds, no matter how well you pre-oxygenate them. Fowler's method. As we know, this is used for anatomical dead space, but it is also used as a measure of closing capacity. The patient is breathing normal air, but what they are essentially breathing is 80% nitrogen. They take one vital capacity breath of 100% oxygen. 100% oxygen has no nitrogen in it. The nitrogen concentration is measured against the expired volume, and the difference is plotted. Here we have the graph. So we start with a full lung at vital capacity or total lung capacity. FRC is written in error there. The patient breathes out all the way down to their residual volume. There is no further increase or decrease in the nitrogen concentration, because this is the termination of that expiration. Initially, when the patient breathes out, there is no nitrogen in the gas at all, because it is the dead space 100% oxygen. Then we get past the dead space and we get to plateau phase, where there has been equal mixing of nitrogen and oxygen, so that all of the gas coming out generally has a consistent amount of nitrogen in it. At closing capacity, the gas is going to have more nitrogen once you get past this point. This is because these airways took in relatively less of the oxygen when it was inspired, as would closed airways, which had the potential to take in far more oxygen. So that meant that when those airways took the oxygen in, they took in more relative to the normal airways, which end up having more nitrogen in them than those airways that were closed at the beginning. This is quite a confusing thing to explain, and I would recommend you go through it 4 or 5 times, remembering that it's a percentage of nitrogen, not oxygen, that it's a fixed volume, which is the vital capacity, or the total lung capacity minus the residual volume, that it's done in expiration, and that you can use it to work out anatomical dead space and to work out closing capacity. This is a topic that you should know very well.